Hey guys, this is Dr. Aman Setia from DBMCI. So we'll discuss some high yield questions. So let us start with the first question. A chest X-ray shows markings in following image. So what they're asking you what these markings are called. So if you see these markings, these are perpendicular markings. What we call them? We call them as curly B lines. These are curly B lines. So cause of marking cannot be. See the question carefully. They are asking you what cannot be. So simple. They are asking you a question like all are causes of curly B line except. So we should know where we see curly B lines. So understand this. These are arrows pointing toward these curly B lines, and these lines we see in condition like in mitral stenosis. Sometimes you can see this in pulmonary edema. You can see these curly B lines sometime in different atypical pneumonia. Atypical pneumonia means it could be either viral or mycoplasma pneumonia. And you can see these line in congenital lymphangiectasia. That is, these are some congenital cause. So we can say congenital lymphangiectasia. So these are the causes of curly B lines. So simple question they are asking you all are causes of curly B lines except. So we can see here nematocele. Nematocele is a cavitatory lesion. So this is I can say it's a cavity or cavitatory lesion. So this will present like cavitation mass, and this is most common cause for this. Most common cause is Staph aureus. Most common cause is Staph aureus, and remember this nematocele is not a cause of curly B line. So answer for this question will be nematocele. So you can see this answer will be nematocele. Okay, coming to next question, you can see let us first highlight the hint in the clinical case. This is a clinical case. So the first hint in the MCQ itself is an age. So 62-year-old. Then hint is female patient. So you can see elderly female, progressively right-sided weakness and speech difficulty since 1 month. So this is means like female is having some sort of I can say hemiparesis or weakness. So there is an impending stroke in this patient. Fundus examination shows the condition as represented in the picture below. So you can see this picture. So let me show you this picture. You can see here disc edema. So this picture is suggestive of papilledema. 2 months ago she had history of fall in her bathroom and struck her head against a wall. Means 2 months before she had a history of fall. So second hint is history of fall. Most likely diagnosis. So by looking at this question, you can see the patient is having papilledema. So papilledema can occur due to hypertension. This papilledema can occur due to some sort of I can say bleed when intracranial pressure is raised, or I can say intraocular pressure is more. So you can see this patient is having let's see the option. Can it be due to Alzheimer's disease? Alzheimer's disease, remember, this will present with a more memory impairment. So this is not the answer. Alzheimer's disease will present with memory impairment. So there is nothing like that. Left parietal glioma. Left parietal glioma will produce parietal lobe syndrome. So again, that is not the answer. Left MCA tertiary stroke. This could be MCA tertiary stroke, but that is very less or unlikely producing papilledema. So this is a case of chronic subdural hematoma. So in chronic subdural hematoma, you will see the patient can develop papilledema and some other symptoms like there can be visual blurring, there can be headache. So these are the signs that we see in a patient of, because there is history of fall almost 2 months ago. So that is a case of chronic. So this is I can say a case of chronic papilledema or chronic subdural hematoma causing papilledema. Okay, coming to next question, which of the following is not seen in ABPA? ABPA means allergic bronchopulmonary aspergillosis. So you can see this is the condition due to aspergillus fungus. So what are the symptoms? You can see in aspergillus, a patient can develop mainly pulmonary manifestations. So wheeze, cough and fever. Cough is seen. Allergic ABPA, how we diagnose? We make a diagnosis like you will see the patient IgE levels are high. So mostly you can see IgE levels are more than 1000. So there is eosinophils counts are also more than how high. So these eosinophil counts are more, IgE levels are more. So it's mainly a respiratory condition. So pneumonia is also seen, recurrent pneumonia is seen. Skin rash is something that is not a classical feature. However, we can see this due to some drug that we use to treat this condition. But remember, skin rash is not a classical feature that we see in a patient of allergic bronchopulmonary aspergillosis. So this is like again an easy question. like we see ABPA as a respiratory condition, so mostly symptoms will be due to respiratory cause. Like I can say there will be cough, there will be fever, there will be sometimes episodic chest pain, there can be recurrent pneumonia, there will be asthma-like symptom, I can say bronchospasm, wheeze. So these kind of symptoms you will see in a patient. A 30-year-old present with diarrhea. So let's see the hint. Diarrhea is the hint. Confusion, high-grade fever and bilateral pneumonitis. So patient is telling you patient is having high-grade fever and bilateral pneumonitis. So that is means patient is having pneumonia. So which pneumonia can also produce diarrhea? That is the hint in the question. So I can say which pneumonia. So this is like a case of Legionnaire disease. So diagnosis for this condition will be a condition called Legionnaire disease. So Legionnaire disease, remember, this is caused by Legionella. So where I can say it is like a patient will develop a diarrhea, confusion, there will be high grade fever, there can be pneumonia. So this is watery diarrhea. Remember, diarrhea is seen in Legionella. Around 20 to 25% patient will develop diarrhea, right? So then you can see some of these patients, they can also develop confusion, because in pneumonia, you know, like curve 65 score, ultimately patient can develop some pulmonary renal component, so urea will be elevated, there will be mental confusion. So that is a feature of any pneumonia, but diarrhea here is the hint. And I can say the treatment for this condition, we can give macrolide or we can give respiratory fluoroquinolones. Following antibodies are commonly seen in Chogren syndrome. So let us see this question in Chogren syndrome, what antibody you will see. So if I start with this antibody, Anti-Topoisomerase antibody. This anti-topoisomerase is also called as, the commercial name is anti-SCL70. Anti-SCL70, and this is seen in systemic sclerosis. Systemic sclerosis is a form of systemic form of scleroderma. So we'll see anti-topoisomerase. If I say anti-centromere is seen in Crest syndrome. Anti-centromere antibody you will see in Crest syndrome. This Crest stands for calcinosis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. So Crest syndrome you will see anti-centromere antibody. So these two, Crest syndrome is what? Remember, this is I can say a localized form of scleroderma. This is localized scleroderma. Means I can say in systemic form you will see more visceral organ involvement, and remember the cause of death here. The cause of death will be pulmonary fibrosis, and that is causing PH. PH means pulmonary artery hypertension. Pulmonary artery hypertension. Anti-U1 RNP is anti-U1 ribonucleoprotein. This is seen in a condition called MCTD, mixed connective tissue disorder, where patient will have 2 or more autoimmune disease in a single person. And anti-Rho, the last option is left. Anti-Rho is also called as SSA. SSA means Chogren syndrome A. SSA. So you can see the name itself, this SSA, this is the answer. Anti-Rho is seen in Chogren syndrome. So in Chogren syndrome, you can see antibodies like anti-Rho. Anti-Rho is also called as SSA, Chogren syndrome A. And second antibody that we see is called anti-La, SSB. We also call this SSB, Chogren syndrome B. Anti-Rho, anti-La. Anti-Rho antibody, remember, this is also present in a condition called neonatal SLE. In neonatal SLE, you will see anti-Rho antibodies. So answer for this question will be anti-Rho. Okay, most common type of MS. So we can have different varieties of MS. So I can say the common type. So let me say this is a person. So we can see different types of MS. So in one condition, we will see patient is having relapse of symptoms. Symptoms are there, then normal. Symptoms there, normal. So that is called a relapsing and remitting type. So means like I can say like January, February, March, a lot of symptom. April, May, very less symptom. May, June, June, July, patient is having minimal symptoms, or then August again there is a flare. So there will be flare of symptom, then normal. So that is called relapsing remitting type. So patient will have a lot of symptoms, then patient will be normal for few days. That is called as most common type. Sometimes you will see the patient is having only increase in symptom. Only increasing symptom means symptom will keep on increasing. We call this primary progressive type. So this is your relapsing remitting type. This is your primary progressive. Third type we will see, we call this initially it will be like relapsing remitting, then this will keep on progressing. We call this as secondary. So just let me say this is your 1. Primary progressive, this will be your 2. Secondary progressive will be like this, means initially it will be like symptom on and off, then there will be keep on progressing. Fourth is your progressive relapsing, means patient is having initially relapsing type, then this will be like a normal type. This is like fourth type. Sometime you will see a fifth type. Fifth type is called, we call this as a very low grade. So patient will have only low grade symptom, like this minimal symptom. We call this benign type. This is fifth type. So just let me label these. This first one will be relapsing remitting type. The second one will be primary progressive type. This third one will be secondary progressive type. And fourth one you can see, this is called progressive relapsing type. And this is called benign type. Benign type means patient will have minimal symptoms. So that is low threshold or subthreshold symptoms. The most common type that we see is relapsing remitting type of MS, multiple sclerosis. And I can say this multiple sclerosis is most common demyelinating CNS disease. Okay, following drug is avoided in Wpw syndrome. Wpw is your Wolff-Parkinson-White syndrome. So you all know, like in Wolff-Parkinson-White syndrome, what we have aberrant conduction pathway. So like normally we see impulse travel from SA node to AV node, then a bundle of phase Purkinje fiber. But if you see there is an abnormal impulse, so I can say with the green I am drawing, this is an aberrant pathway. Impulse is traveling through aberrant pathway, that is called this aberrant conduction pathway. So impulse is not normally traveling, like I can say this is your SA node, this is your AV node, then you can see bundle of phase and Purkinje fiber. But here impulse traveling by some abnormal pathway or aberrant pathway. This abnormal pathway is called as bundle of Kent. So in this I can say which drug is avoided. So remember there are patient will develop arrhythmia, so which drug we should avoid. So remember, in this patient we will avoid drugs like digoxin. So digoxin is avoided. The reason is this digoxin will increase contractibility. So you will see there will be a direct connection because of this bypass tract. We call this bundle of Kent or bypass tract. If you give digoxin, so I can say if you give digoxin or any other drugs that increase contractibility like verapamil, because you will see this will increase conduction bypass. Adenosine procainamide. Adenosine basically that this is the drug of choice for PSVT, so we can give adenosine in patient with PSVT. Procainamide, amiodarone also we can give because these are antiarrhythmic drugs. So these drugs can be given, but remember digoxin is avoided because this will increase conduction by bypass tract. Now if I say what else they can ask you in WPW, they ask an MCQ. In Wpw syndrome, here you will see a classical finding, that is what we call in ECG, you will see delta waves. What is now delta waves? Understand this. This is like a slurry upstroke of QRS. So you will see this is your P waves. Then you will see QRS will be like this. This slurry upstroke of QRS is called delta wave. So this is a slurry upstroke of QRS that we see in a patient of Wpw syndrome. Okay, so this is the condition. They are asking you what is the diagnosis. So first you should know what this condition is called. So this condition is associated with, so this is called Keratoderma Blenoregica. We call this as Keratoderma Blenoregica. So this is a condition. You can see there will be painful lesions in palms and sole, and this is mainly seen in a patient with Reiter syndrome or reactive arthritis. This reactive arthritis is also called as Reiter syndrome. So in Reiter syndrome, initially patient will develop I can say The manifestation, like there will be patient can have enterocolitis, or patient can have some STD, like there can be infection with chlamydia, mycoplasma, ureaplasma, yersinia, salmonella, shigella. These are the infective agent, and ultimately then the patient will have a classical triad. That triad will be, there will be conjunctivitis, so I can say can't see, can't pee, and remember, can't dance with me. Can't dance with me. So can't see means patient will have conjunctivitis. Can't pee means there will be urethritis because of chlamydia or yersinia or any other infection, and there can't dance with me means there will be arthritis. So conjunctivitis, and they will have, later on they can develop this classical skin lesion. We call this Keratoderma Blenoregica. So this is a case of reactive arthritis. In psoriasis, you can later on develop psoriatic arthritis. For this, we have a diagnostic criteria. We call this Casper criteria. For lupus, we can develop a lupus arthropathy. Like sometimes there will be deforming. Initially, it's non-deforming. Later on, it will become deforming. We call this Jacquard's arthropathy. In seborrheic dermatitis, you will see seborrheic dermatitis basically in the facial areas, not here, not in palms and soles. Okay, now see this condition: a 60-year-old. So let me highlight this: 60-year-old patient with difficulty in walking and pain in knee since 6 months. Pain in the knee 6 months. So when I see a question on knee pain, morning stiffness for 5 to 10 minutes sometimes. So this is given to confuse you. Morning stiffness, you should mark the answer, you should think, and you will mark the answer rheumatoid arthritis. So this is just given to confuse you. So understand this. In rheumatoid arthritis, it will last for more than half an hour. So more than half an hour, sometimes more than 45 minutes. So here given only 5 to 10 minutes. So that is not a hint. So here the hint is pain in knees since 6 months. Considering age and complaint of patient got an X-ray done. On looking X-ray, think of it being what you can see here. So you can see here, now we can see the changes in the X-ray. You can see the degenerative changes here, right? So you can see this like there is a degenerative changes in the articular cartilage. So this is considering age of the patient. So psoriatic arthritis, remember, this is mainly affecting DIP. In ankylosing spondylitis, this will affect your spine, and gout will mainly affect your first MTP. So whenever I see a question on knee joint involvement, so I'll have 3 differential in my brain. So if you see the involvement of knee joint, so there will be 3 differentials. First differential, and the most common cause will be OA. OA means osteoarthritis. Second differential which I should think of is your pseudo gout, because pseudo gout is also the most common joint affected knee. And third will be septic arthritis. Septic arthritis. So by looking at X-ray, I can see there is degenerative changes. So the diagnosis is clear here, osteoarthritis. But remember, in pseudo gout, they will give you some hint, like there is calcium hydroxyapatite or calcium pyrophosphate crystal accumulation. That crystals they can mention, or they will give you some history related to calcium overload. In septic arthritis, the patient will be febrile. There will be fever, there will be swollen knee. So you can see there is no as such swelling in the knee. There will be swollen, a painful knee. There will be feature of sepsis, leukocyte counts will be high. So this is again a case of osteoarthritis. Okay, coming to next question. A patient of age 52-year-old patient with acute symptom of fever, headache localized to temporal lobe. Here patient is having headache and jaw pain whenever she talk or chew. So that is a jaw pain or claudication patient is having. ESR and CRP. What is the diagnosis? So you can see like mostly it is seen in female more than 60 years, but here 52 is given. So based on the symptom, you can see headache is there, fever is there, temporal lobe involvement means temporal arthritis, jaw pain. So that is a classical case of temporal arthritis. Temporal arthritis is also called as giant cell arthritis. Temporal arthritis is also called as giant cell arthritis. So remember, here the patient will complain of common complication like there will be headache. So most common symptom you can see headache. Then patient can develop jaw claudication or jaw pain. So pain during mastication, during chewing, during sometimes facial pain during smiling also. Then remember, the most dreaded complication or most dangerous complication is there is risk of blindness. There is risk of blindness, and a few patients later on can develop a complication that sometimes they ask in MCQs. So this is associated with the condition, like some patient will develop fatigue, joint pain, muscle pain, that is called polymyalgia. So basically it's a rheumatoid arthritis like picture. We call this polymyalgia rheumatica. Polymyalgia rheumatica. So that is seen here. 32-year-old male patient. Coming to next question. 32-year-old male patient. Hospital with chief complaint of painful and recurrent genital ulcers. HLA B57 is preponderance. So what is that? You can see the genital ulcers in the image. So these are the pathognomonic feature where we see oral ulcers, genital ulcers and the positive pathology test. I repeat, oral ulcers, genital ulcers and positive pathology test. This is the classical case of Behçet syndrome. So we also call this Behçet syndrome or silk root disease. So this is the case of Behçet syndrome. So patient will develop oral ulcers. There will be genital ulcers. And there will be a positive pathology test. So most common ulcers, I can say most common ulcers are oral ulcers, but most specific ones are genital ulcers. So you can see the patient is having, both are painful. So recurrent, on the recurrent word is the hint. So this is like a young patient and HLA B51 or sometime HLA B50, these are classical association. Right. So this is a classical case that we see in a patient of Behçet syndrome. So diagnosis will be Behçet syndrome. It is not an STD because there is no history of sexual intercourse or any infection. No gonorrhea again because there is no HLA association with any of these STDs. So gonorrhea, syphilis are ruled out. So diagnosis will be Behçet syndrome. Okay, 38-year-old female. You can see 38-year-old. Chief complaint of dry eyes, bilateral parotid gland swelling and difficulty in chewing food. What is the diagnosis? So you can see dry eyes is a hint. Parotid gland infiltration. So you will see this parotid gland swelling means there will be lymphocyte infiltration in parotid gland. Lymphocyte infiltration into parotid gland. So what could be the possible option? Let's see. Keratoconjunctivitis sicca means Chogren syndrome. So basically here you will see the eye manifestation. So that is only eye manifestation that is not seen because they have mentioned dry eyes along with some other things. So in keratoconjunctivitis sicca you will see only problem in the eyes. So here patient is having problem in the parotid gland as well. So dental caries, no, dental caries will not produce parotid gland swelling. Even bilateral is unlikely. Behçet syndrome is not having such presentation. In Behçet I told you they will have recurrent oral ulcers, recurrent genital ulcers and positive pathology test. So this is the case of Chogren syndrome. This is the case of Chogren syndrome. You can clearly see the parotid swelling. So differential diagnosis for this will become mumps. But considering the age of patient, 38-year-old female, then dryness in the eyes, how you will manage this? So you'll manage this by giving artificial tears. So now even we have new drugs for Chogren syndrome. They can ask an MCQ. So drug that is approved for dry mouth and dry eyes, Cefamylin. If there is no improvement with Cefamylin, what we can give? We can give pilocarpine. So this is a case of Chogren syndrome. Okay, so patient is known case of Crohn's disease. So what we can see with red tender finding? So you can see this red tender finding, we call this as erythema nodosum. So erythema nodosum is a cutaneous manifestation which we can see in many conditions, right? So like it can occur after drug. You can see this with sarcoidosis. You can see this with Crohn's disease, ulcerative colitis. So this is one of the, I can say, extra intestinal manifestation of Crohn's disease. So answer is erythema nodosum. Sweet syndrome, pyoderma gangrenosum, ecthema, these are also manifestation that we see in Crohn's syndrome. But remember, these are not presenting like this round tender lesions presenting over your skin of your tibial area or in your legs. So these can be present anywhere. So this is the case of erythema nodosum. Okay, now see 7-year-old girl. So let us see the hint first. 7-year-old girl. Complaint of hyperactivity. Girl is very active. Injury to self means self-mutilation. Learning disability means mental retardation with prolonged history of seizures. So what you can see? What you can see here? So let's see one by one what they can see. So first let me see. I'm knowing nothing about this question. So I can see something in the face. I can see these are. You can see in the nasal area also. These are called adenoma sebaceum. So this is called adenoma sebaceum. There is hypertrophy of sebaceous gland. hypertrophy of sebaceous gland. So in considering the age of patient, the recurrent seizure is the hint. So prolonged history of seizure means patient having seizure. So this is, I can say, you can see here in MRI, this is an MRI brain, you can see there are multiple angiofibromas. Okay, even if MRI is not given, you can see these are, sorry, let me just correct this. You can see these are like adenoma sebaceum in this nasal area. Then we can see multiple angiofibromas here. In MRI, you can see these lesions. What we can call them? We can call them like these are some tumor-like growth. These are tumor-like growth. We call them potato-like tumor. We call them potato-like tumors. Right? These are potato-like tumors. We can call them subependymal hematoma or tubers. So these are some of the tumors. So there is a condition which present with epiloa. Epiloa means a classical triad. Epiloa. Epi means epilepsy, which is given here, seizure. Low means low IQ. So epilepsy is given. Low IQ. Learning disability means low IQ. And adenoma sebaceum, which is given in the image. So this is the classical finding we see in a patient of tuberous sclerosis. Right? So understand this periventricular nodular heterotrophia is a rare conditions where you will not see, you can see seizure patient can develop, but you will not see the cutaneous finding. Wpw syndrome, again you will not see seizures here. Then you can see it in MEN1 syndrome, you can see we have three P's, like pituitary tumors, parathyroid tumors, and parathyroid tumor or parathyroid hyperplasia, and pancreatic tumor like gastrinomas. So there is nothing like MEN1 syndrome. So diagnosis is tuberous sclerosis. So this is an autosomal dominant condition, and I can say the other feature you can see there will be skin rash. That rash is called as ash leaf spot, hypopigmented rash. Sometimes you can see a boggy swelling in the truncal area. That boggy swelling is called as shagreen patch, hyperpigmented boggy swelling. So these are features that we see in a patient of tuberous sclerosis. Okay, let's first see the hint. 32-year-old male. Following image finding. So let's see the image. What you can see in this image? I can see there is an image. This is a male patient but looking like a female. You can see the nose. This node is like we can call this a saddle nose. So there is nose deformity. You can see the patient is having nose deformity. Then you can see some rashes are there in the skin. Nothing else. Right. So this is, you can see saddle nose and nothing classical here. What else we can see? Necrotizing vasculitis. Means it's again a question on vasculitis. All of the following are seen in classical triad except. So let us see what we have. So this is like a patient with saddle nose. So where we can see necrotizing vascular saddle nose, we can see in a condition called Wegener's granulomatosis. So in Wegener's granulomatosis, what we can see patient can develop upper respiratory tract infection. There will be lower respiratory tract infection, and there will be kidney manifestation. So this is a classical triad. Classical triad means you can see the patient can develop a recurrent URTI, upper respiratory tract, like there can be nasal polyp, rhinitis, sinusitis. LRTI means there will be bronchitis, so patient with complaint of hemoptysis. Kidney manifestation, patient can develop hematuria. So remember, rhinitis, hemoptysis, hematuria. So these are the classical findings. GIT involvement can occur in few patients, but that is not considered a part of triad. That's not classical. So answer will be GIT. So other features are seen. So GIT involvement is not seen. So this is a case of Wegener's granulomatosis. Remember, in Wegener's you will find C ANCA. The antibody that will find is C ANCA. And treatment for Wegener, steroids mostly are not effective. So how we manage? We manage by giving a cyclophosphamide. Okay, higher magnification view is shown using Gallia's silver staining in the image below. So silver stain is the hint of middle temporal lobe. Identify the structure indicated by arrow and arrowhead respectively. So arrow and arrowhead, they are asking you what it is. So you can see in this image. So what we can see in this arrow, these are like a triangular structure. These triangular structure are called as neurofibrillary tangles. Then we can see these are like a plague. We call these tangles, they can make a plaque. We call this neurofibrillary tangles, like amyloid protein is depositing, so we can see this neuritic plaque. What we call this? We call this neuritic plaque. So neuritic plaque and neurofibrillary tangles, these tangles are made up of tau proteins. So now most of you are knowing the answer. It's the case of Alzheimer's disease. So let's see the option one by one. A fibrillary nature of tangles and neuritic plaques seen in Alzheimer's disease, that is a possible option. So let me keep this an option. This could be the answer. Fibrillary nature of tangles and neuritic plaques seen in Parkinson's disease, no, they are seen in Alzheimer's disease. Neurotic, again Parkinson's is not the answer. Neurotic plaques and fibrillary nature of tangles in multiple system atrophy, no. So in Parkinson's disease, what we will see? We will see in Parkinson, you will see there will be pallor of substantia nigra. So in both these questions, in Parkinson's disease, what you will see? You will see there will be pallor of substantia nigra. You will see that substantia nigra will be less black in color. Sometime in MRI, you can see there will be loss of swallow tail sign. That is a rare, not seen again in every patient. In MSA, multisystem atrophy, you will see in MRI hot cross bun sign. Hot cross bun sign. So this is a case of Alzheimer's disease, and what we will see? We will see neurofibrillary tangles and neuritic plaque. With respect to the type of above mentioned headache, which the following is correct. First, you can see the localization of this headache. This is like hemicrania. This is hemicrania. Hemicrania means half-sided headache. So half-sided headache is most likely could be your migraine. So let me see the option. There is a repeated episode of headache lasting for 4 to 72 hours. That is true. So remember in migraine, remember how we make a diagnosis of migraine. So migraine diagnosis we make, so patient should have headache. That should be unilateral. The duration of headache should be 4 to 72 hours. The headache is pulsatile in nature. So patient is having a unilateral headache of 4 to 72 hours duration, pulsatile in nature. And remember, this headache is never mild headache. It is either moderate or severe. So it is moderate to severe headache. Then I can say point number 5, I am writing here. The headache will associate with nausea or vomiting. And point number 6, which I am writing here, there will be photophobia or phonophobia. So you can see I have written these 6 features. So how to make a diagnosis, clinical diagnosis of migraine we make. On which ground we make a diagnosis? If you see any 2 features from this list, any one from nausea or vomiting. If both are present, that is very good. If any one is there and any one from this list. So 2, 1, 1. Remember 2, 1, 1. This is how we make a diagnosis of migraine. So migraine diagnosis is clinical. So let's see now option. This repeated episode of headache lasting 4 to 7. That is true. This is precipitated by caffeine, contraceptive pills, sound, hunger, excess stress, lack of sleep. Yes, that is also true. Migraine can be precipitated if you consume a lot of coffee, especially after 7 p.m. Oral contraceptive, yes, that is also true. Hunger can also precipitate. Vasoactive neuropeptides, CGRP, this is calcitonin gene-related peptide, CGRP, plays an important role. That is true. There are many hypotheses for migraine. The most accepted is CGRP. Patients who are hypertensive are more prone this. No, this is false. So even like migraine is seen in young patient more than old patients. You can see more younger cases of migraine and they are non-hypertensive. So there is no relation with hypertension. So answer is ABC. So let me see, the answer is clear, ABC. The following lab picture suggests type 2 hepatorenal syndrome. Hepatorenal syndrome is HRS. Hepatorenal syndrome. So there are different types of HRS. We should know 2 main types. One is called HRS type 1 and second is called HRS type 2. In HRS type 1, what we see? We will see doubling of serum creatinine and half of GFR. GFR will be, so serum creatinine will be double and GFR will be half. And this will occur in less than 2 weeks. So this is like a progressive disease. In this type 2, I can say here you will see there will be increase in serum creatinine. and there will be decrease in GFR. But this is I can say over many weeks. So this is like a slow or gradually over many weeks. So I can say this patient is like fairly stable, but there will be one more finding that we see. The patient will develop, along with this you will see there will be refractory ascitis. Refractory ascitis means, so patient is having ascitis and that fluid in the abdomen is not resolving even when you give like maximum dose of furosemide and spironolactone. Like this an ascitis that is not showing response when you give even I can say up to 160 mg of furosemide and 400 mg of spironolactone. That is the maximal dose. That ascitis, and plus salt restriction diet. So I repeat, salt restriction diet, Lasix of furosemide 160 mg, spironolactone 400 mg. Still there is no relief. That ascitis is called refractory ascitis. So let us see. But make sure to make a diagnosis of HRS, there should be no prior kidney damage. The previous KFT report should be normal. There should be no use of any nephrotoxic drug. So let us see the option one by one. Progressive impairment in renal function and significant reduction in creatinine within 1 to 2 weeks. No, this is a case of HRS type 1. This is HRS type 1, but they have asked you type 2. Reduction in GFR with an elevation of serum creatinine, but is fairly stable. This could be the answer. Progressive impairment in renal function and significant impairment in renal function, increase in creatinine clearance. Now they are giving you increase in creatinine clearance within 1 to 2. No, it's not increase in creatinine clearance. It is decrease in clearance. Right? Increase in creatinine level but not clearance. So this is not the answer. Reduction in GFR, that is 2. Decrease of serum creatinine, low. Serum creatinine is increased. Now see, the question they are confusing you with the creatinine clearance and creatinine level. Creatinine levels are more, that is bad for you. Creatinine clearance is more, that is giving you an adequate GFR. So GFR we can calculate. So indirect reflection of GFR. There are different methods to calculate GFR. Like nowadays what we prefer cystatin EPS cystatin C method. That's the best method. Then we have MDRD equation. Then we can use Cockcroft-Gault formula, we can use creatinine clearance, we can use insulin clearance. So more is the clearance, that is better for you. So this is progressive impairment in renal function and significant reduction in creatinine clearance means decrease in GFR. Reduction in clearance means reduction in GFR, so that is within 1 to 2, that is HRS type 1. Reduction in glomerular filtration rate, GFR is reduced, elevation of creatinine and is fairly stable. This is the answer for HRS type 2. Progressive impairment in renal function. Kidney functions are impaired and significant increase in creatinine clearance. If creatinine clearance is more, it means GFR is more. That's even good for you. So this is sometime we can see. So this is a case of HRS type 1. Sorry, this is HRS type 2. If I say this thing will be a case progressive impairment in renal function and significant increase in creatinine clearance within 1 to 2. This can be sometime we can see in AKI. This sometimes we can see in a patient of AKI, right? So AKI is having certain phases, like initiation phase. We can see sometimes this thing AKI initiation phase. Sometime in the recovery phase also we can see this. Reduction in GFR with decrease in creatinine levels. No, if GFR is reduced, creatinine will increase. So that is even not seen anywhere. So this is the answer for this HRS hepatorenal syndrome type 1 and type 2. So this is about some of the important questions. Just remember, keep working hard, keep revising. See you in the next video with some more knowledgeable session. Bye bye. Till then, take care. Remember, you can, you will. Bye bye. Stop करना क्या?